I'm Rachel. I'm one of the kidney transplant coordinators. I do pre and post transplant. For them, they have to go through a lot of testing to complete their eval. They have to get cardiac clearance. They have to go through extensive lab testing, chest x-rays, EKGs, stress tests, and echoes. They have to do ultrasound so we know where to put them. They have to do cancer screenings like colonoscopies, pap smears, mammograms. They have to get dental clearance. So it's about a 6-month eval period that we have for them. If they complete it, they get all the clearances that they need. If anything specific comes up, like gallbladder polyp, we're thorough. We'll send them to GI. So it's kind of extensive. We make them go through a lot. Once we list them, the average wait time to get a deceased donor kidney is about 5 to 10 years. Blood type O's tend to wait the longest because they can only receive O and it's more common blood type. Blood type B tends to wait the second longest, and then it's A, and AB waits the shortest because they can receive blood from anybody. So we tell them, like, you're gonna wait a while unless you have a living donor. This is the time where you're waiting.
So I'm sorry, can you clarify again, how do they get referred to you?
So usually by their nephrologist or their dialysis center. They'll tell them you should go to Christ, go there, get your workup done, and then they'll come to us. So they get referred usually.
And then with the living donor, does the potential recipient normally know them or connected to them through some sort of
Usually,
connection like that?
But we've been seeing a lot of social media anonymous donors come in for people, which is really hard because with the donors, even if they know who their donors are, we can't tell them anything about them. So if they've been putting themselves out there on social media, through church, through their community or whatever else, and they ask us if anybody's came in for them, we can't tell them. Unless they go through their entire workup and they're actually a match to them and we're getting things ready to go. It's a little hard, but the living donors are cool. They work a little bit longer. They work quicker than the deceased donor transplants, and obviously they get transplanted much sooner than having to wait that 5 to 10 year wait period. So we really try and encourage our recipients to have living donors for those reasons. And then the recipient's insurance should pay for the entire donor's workup, surgery, everything. So everything should be free for them. And then there's a little bit of a cushion for them too, because if for whatever reason in the future something were to happen to their remaining kidney, UNOS likes to take care of their donors, and my colleagues have seen it once. This person was transplanted in 2 days after donating and having kidney failure herself. So.
And I'm sorry, what is UNOS?
UNOS is the United Network for Organ Sharing. They're like the governing body of transplant.
Oh, okay.
So they make a lot of rules, regulations, stuff that we have to follow. But living donor is cool. We've seen, we actually do have a swap program too, which we actually just did, where if a donor pair aren't a match to each other, they go in this swap program. We swapped with Rhode Island and New York, and got a living transplant that way, so that was cool too. So a lot of benefits of living donation. On average, they last about 20 years. Deceased donor lasts about 15 to 20 years. So deceased donor is still a good option. Once our patients, they have to be on the wait list regardless of if they have a living donor or a deceased donor. If they wait and they do get a deceased donor, we only see them once a year. We update a little bit of their testing. There's a couple things that move up our patients on the wait list. One of them's age, so they try to match. If it's a super young donor, usually younger people will come up first for it. Another thing is dialysis or wait time. The more wait time you have, the more you'll come up. If you have a lot of antibodies, so people who have like donor-specific antibodies from previous blood transfusions, previous transplants, or women who had pregnancies and developed antibodies, it makes them really hard to match them to donors. So we look at that too. The more antibodies they have, it's called a PRA score. The higher it is, closer to 100, the more they'll come up for offers because it's hard to match them. And usually people who are 100% sensitized to donors will have to get a donor from East or West Coast, because locally they have antibodies to donors. Very strange. Very strange. So we look at that. There's a couple other factors too that move people a little bit higher. A perfect match will move somebody higher. We look at 3 antigens. There's 2 for each part. So if there is 6 HLA match, that's a perfect match. Not quite exactly perfect, but that's what we look for. So it's not quite like heart, where you can throw in a balloon pump and they're all of a sudden status 1 or 2. We can't really do that. So it's just a couple of those things. Once we do have an organ offer, and we get organ offers all day long, we look through them, we review them, we can see all of their labs, we can see their medical history, their testing, their blood work, their vitals. We review them, we'll code our patients in or out. If we're like top 10, we'll keep an eye on it. Immediately when they come up to the ICU, they're supposed to get a stat 12 lead, stat chest x-ray for central line placement, stat ultrasound of the transplanted kidney with Doppler, and you can indicate left or right side, stat CBC, CMP, and troponin, and then we usually do a Lasix push of 40 IV once. The basics on the day of surgery, they're usually NPO, except for meds. Post-op day 1, we start to advance their diet to clear liquids, and then the baseline, which we talk about as a team, they'll need orders to advance from us. Day of surgery, they're bed rest, and then post-op day 1, we'd like them to get up to the chair and get moving, which they're pretty resistant, but they should. They have that PCA pump for a reason. Vital signs will be Q hour here, daily weight in the morning. Eyes and O's are obviously huge, which you guys do that every hour anyways. Once they get to step down, you can kind of communicate with them that it could be 4 hours, eyes and O's. Foley care per policy, it's not to be removed. I think you guys know that. It'll be in the nursing communication orders to leave it in, that and the central line. They're supposed to be on SCDs while they're in bed. Have TEDs on at all times, and be using the incentive spirometer to clear those secretions, kind of similar to everyday post-op. Wound care, it's okay to change the surgical dressing if it's saturated. Usually we leave it alone for 48 hours, but if it's getting pretty gross and looks like it needs to be changed, you can change it. It's perfectly fine. We don't need to be the ones to change it the first time. It's just some 4x4s and then tape over it and ABD if needed. So that all says, obviously, reporting saturation, bright red blood, signs and symptoms of infection, but otherwise it's okay to just change it as needed. Some of the nursing communication orders are in here too, like not removing the Foley, not giving heparin or NSAIDs, not giving vaccines. I put in some vital signs here to notify us about if they have a temp, if their systolic is above 170 or below 100. But usually blood pressure management, we want them to be a little hypertensive after surgery. We want a lot of blood flow to that kidney, so if their systolic is hanging out around 170 and then all of a sudden it goes to like a normal blood pressure, that would actually be concerning to us. So any fluctuations that happen in vitals, if they're correlating to, if their blood pressure drops to the 120 systolic and so does their urine output, that would be concerning. So just kind of seeing what else is going on in the picture, but just kind of basic stuff. Fluids, the alternating of fluids, we alternate between 0.9 and 0.45 because when they're peeing a lot, and if we continuously just give them 0.9, their sodium will be way too high. So that's why we alternate. I think your protocol has been in there before. We usually do, when their urine output is between 50 and 500, we do ml per ml replacement, doing urine output checks every hour.
Can I ask a clarifying question about that?
Yeah.
When we're doing the ML to ML replacement, do you want us to switch out the bag? Like, 0.9 the 1 hour, 0.45 the other hour? Or can we use up the whole bag of 0.9 then switch to?
Usually it's per
Point-
hour. So
okay.
0.9. So for this hour, if their urine output's 125, we'll do 125 replaced back with 0.9. The next hour,
Got it.
yeah, 0.45.
Okay.
I usually, you guys probably have it down. I would just pause the pump so that it would beep and remind me to go in there. I would just delay it for 60 minutes and then put an output in here, urine output. I put in a little starred thing that recipients who received a deceased donor transplant might not make any urine right away. So it might be normal to have no urine output or less than 30 because there's different deceased donor options. There's brain dead and there's ones that have to die of cardiac death who aren't quite brain dead yet. The cardiac death donors tend to have delayed graft function. So it may take a couple days up to a couple months even where they're not making any urine. They still need dialysis, but that's why we check when that happens. We look at the ultrasound of the kidneys, making sure that it has good flow and that it will eventually wake up. Which it does. Sometimes it just takes a little bit. They need a couple dialysis sessions and then all of a sudden they'll open up and start dumping urine.
Okay.
So after the kidney is replaced, they may need dialysis, because we had a patient like that today, and I was wondering, because I don't know that much about it, why, I thought maybe it didn't work or something. Okay.
Yeah, sometimes they'll just need it until that kidney opens up and starts fully functioning. They might be a little sleepy.
Okay.
Yeah, so delayed graft function, that's why it's not working right away. It will work though. CVP monitoring, you can hook up a CVP monitor to the distal end of the dialysis port or their triple lumen. We'll say if the CVP is less than 7, it's okay to give a 250 bolus up to like 6 times and then notify us once it's not coming up. Pain management, they'll be on the PCA pump while they're here, and then we can DC it a couple days after their surgery. Immunosuppression, when they have to get the IV thymoglobulin, it's important that it has to be going through a central line. Sometimes people haven't known that and because there's different concentrations of it, so if you put it through a peripheral line, it could be damaging. It could be bad. So central line and immunosuppressants, obviously they're given at the same time each day. They're on them for life. And then other routine meds that we give is cefazolin, kind of just prophylaxis for surgical to prevent any infections. For the first 48 hours, they'll be on that. We have them on a lot of stool softeners, obviously, with the anesthesia and with their pain meds and stuff. GI prophylaxis, we'll put them on. We'll even send them home on Pepcid to take because the immunosuppressants are hard on the stomach too. They'll be on Bactrim and Valsite, which are to prevent any bacterial and viruses like CMV and EBV are 2 big ones for transplant. They'll be on those about every Monday, Wednesday, Friday for an entire year. And then we'll usually wean those off. Routine labs, CMP, CBC daily, MAGFOS, and a tacro level. Tacro should be drawn about 30 minutes before you're giving it, so around 6:30 the tacro should be drawn. And then when they go to transfer, we'll DC the A line, DC the CVP monitoring, not discontinuing the central line or the Foley, and then you can let 3 South usually know that they can do vitals and I's and O's Q4.
And typically they've only been in the unit 1 or 2 days, right?
Yeah, their whole hospital stay is usually like 3 to 5 days total. It's not too long. And then once they leave the hospital, they have to follow up with us in clinic twice a week for an entire month. So usually like Mondays and Thursdays they'll come do labs, they'll get their tacro drawn, all their kidney function labs, we'll do ultrasounds as needed. We'll see how well the kidney's functioning for that first month, twice a week. The second month it's once a week. The third month kind of tapers off to every other. They'll first see us at the 6th month and then annually. And they'll just follow up with their NEF or their PCP and see us once a year. Yeah. Any questions for me or Dr. Mittal? Yeah.
What's the hospital stay for the donor, for the living donor?
It's like 1 day.
Yeah, typically the living donor is a laparoscopic procedure, so they go home the next morning. I'll just pretend I'm eating.
Okay.
Yeah, It's pretty
Interesting.
straightforward procedure for the donor. The recipient typically stays overnight here in the stick. If everything is okay, they go to 3 South. So say we do a transplant Tuesday, they're here Tuesday night, Wednesday they go to 3 South, and Friday they go home. So living donors usually make a lot of urine. Like Rachel said, the deceased donors may have a period of acute tubular necrosis, ATN, and so they may not make any urine after the transplant right away. It could be a few days or a couple of weeks before they make urine.
Are there times that the living donor doesn't make urine either?
It's very unusual. So if a living donor doesn't make urine, that's a problem. So, because the cold ischemia time for the kidney to come out and go back into the recipient is very short. So they usually work right away. Yeah.
Okay.
Yeah.
Anybody have any more questions?
Would we see signs of rejection early on? And what would that look like?
It's very rare to have rejection that early
Okay.
on day one. So it's it
Okay.
doesn't happen.
Yeah.
Dr. Chabra is here. She's our medical director, and we defer management of the blood pressure, and we work together with Dr. Chabra and some of the other transplant nephrologists like Dr. Thomas. So.
Yeah. I guess too, if you guys would ever wonder like what we look at for deceased donors, like we do look heavily at their creatinine, how old they are, what they died from, if they're dying from brain death or cardiac death, what their medical history looks like. We usually don't take donors with a creatinine much higher than 1.9. We look to see their CT scans, if they've had any kidney stones in the past. That's usually kind of, for a living donor too, that's a contraindication. But if there's any damage to anywhere in the kidneys, we look at the anatomy, how big they are for our recipients, things like that. So we look at it extensively, review it with these guys, and then we'll either accept or deny it. We do look at warm time too, so if it is a donor who has to die of cardiac death, we pretty much only give them about 15 to 30 minutes to actually pass. And that's the warm time. And then cold ischemia time total for an import is up to what?
If an import, we say try to get it here before 24 hours. So.
Yeah. So the kidneys can be out and be transplantable up to 30 plus hours.
Yeah, we just put one in at 33 hours, but on the pump, on the pulsatile perfusion pump, and it worked right away.
Yeah. So sometimes we'll say, especially if it's being imported and there's going to be kind of a long wait, the kidneys can be pumped, so there's preservation fluid going through them, and then we can also look at the flow and the resistance, the pressures in the kidney that way too.
And we are always around to answer more questions. So.